3 days in NIH. Lehan was there at the time, and then Alexander Buckle and Kate Gervais, Mike Gomeran, and Jonathan Plant, Lehan, they're all there, and Scott was there. So we had a fantastic time in the 2.5, 3 days. Learned a lot. If we go back to my first GIST patient back in 2002, I knew nothing. I knew nothing about GIST. Never heard of GIST in my life when I was a very junior consultant, very junior physician, and I had 2 patients for the whole year. Now I've got in excess of 400 patients in my practice. That's all GIST patients together. So in 2011, we came to an NIH clinic, and we said, okay, we can actually model ourselves on the NIH using the multidisciplinary collaborative approach. So came back, and so PAWS GIST was born. And as great ideas happen in the UK at least, great ideas born in a pub. Okay, if you go back to 1953, Watson and Crick talked about DNA, the double helix, in a pub called Eagle Pub in Cambridge. And we had the same kind of a really bright spark idea in this pub in Oxford in 2011. Jane Bessington, myself, Judith Robinson, who was the chair of the GIST UK, and her husband David. So we met here for a few glasses of wine, I think, possibly a beer. So we came up with the idea that we should have a model similar to America, the National Clinic, Welfare Clinic. And we chose PAWS as in a kind of a PAWS kind of thing, Paediatric Adolescent Wild-Type Syndromic, that included the NF1 and the SDH Deficient patient. And then from there, from 2011 to 2014 was hard work. Not from me, but from the GIST UK, including Jane, raising the funds. And also we set up a website. We got a PAWS GIST-Clinical website, and the website has various pages, including the who we are, and then what you can find, and you can find out more about the PAWS GIST and what research is taking place, any extra clinical information. And the beauty of the website and the way the clinic was set up is that I chose Cambridge because I live in Cambridge, and we felt that it has to be a regional centre. And it's easy to get to as well, and it's not London. London is almost impossible. It's very, very expensive as well. So we chose Cambridge. And one of the things we learned is that there are dozens of PAWS GIST patients, the wild GIST patients, but we don't know who they are. And right at the beginning, we weren't doing the testing routinely, and then genomic testing became standard of care. Now every single GIST patient who comes into a clinic gets mutational testing done in UK, so that just happens. And any patient who's got a wild type GIST clinic is flagged up. And with the support from the GIST UK and with the Jane Bessington Drive, they got a web discussion listserv, so they can actually talk to one another on the web, and they can be directed to the clinic. Another thing what happens with the clinic is the patients can register online. So they can register for the next clinic online, fill in the details, your name, address. There's a unique number in UK called NHS number, National Health Service number. That's unique to you, and that follows you all the way through the country. It doesn't matter where you are, that number is linked to you for your healthcare records. So if you know the NHS number, we can track you anywhere. Your operation can happen in Manchester, and your treatment is done somewhere else, say for in Belfast or Glasgow, but we can actually get all this information from one place. So they register, and also they tick the box that the information can be shared with the patient director, which is Jane Bessington, and this form comes to us automatically. And then we initiate the process. Or the attending oncologist, the patient's oncologist can write a direct letter to us, or fax a letter or email, say, by the way, I've seen this patient, I would like this patient to come to the clinic. So either way, the patient comes to us, and we have done 12 clinics so far. Just to highlight this process starts about 2 to 3 months before the clinic starts. So it's a long, drawn-out process. It's not just happening like that. And we have a cutoff point of 2 weeks before the clinic. But often, sometimes we are asked to see the patient urgently because the patient is desperate to see the specialist team. And the specialist team is very similar to NIH. So we have oncology, surgery, pathologist who's mad about GIST, which is great. And then we got Ruth Casey, who's an endocrinologist, and we have clinical geneticists, specialist nurses from Royal Marsden, and also radiologists. It's very rare to see a clinic where a pathologist sits in the consulting room and you scratch your head, what is he doing here? But Olivier Giger, who's a molecular pathologist, he's fantastic. So he actually sits all the way to the clinic. As Jane was saying, the first clinic was 12 patients. And we started at 9 in the morning and finished about 8, 9 o'clock at night. And we roughly see about 6 to 8 patients on average per clinic. And they get unlimited time. There's no time limit to the consultation. So we don't look at the, oh God, this is time up, now we go. If they need time, they get time. And like NIH, what we have done is we meet up with the patients and the families the night before. And as it happens, the tradition we meet in a pub. And the pub is basically, we have a very social, kind of a very informal drinks, meal, and shoot any questions, and also prepare them for the next day so that they spend the time efficiently, knowing the time is precious both for them and also for us as well. So what questions to ask? What you want to get out of the clinic consultation next day, and then so that they're actually focused on the clinic. So meeting in the pub actually is a very important thing in the whole running of the service. That's more. So what we have done is, we've done, say, 12 clinics so far, 70 patients, but some of them actually they come back more than once. So the actual total number is close to 90. 90 patients have actually attended, so 70 patients are new patients. And this is, if you imagine, 60 million population in the UK, and the clinic started in 2014, so we've got 12 clinics, and we've got 70 patients. And I'm sure there are patients there who are in the other parts of the UK, which we haven't, we know who they are, but some of them don't want to come. That's fine. And as you're saying, so females more than males, and very young median age. And I think what we learned is no two patients are the same. You've got SDH deficient GIST patients sitting here, and SDH deficient patients sitting here. So they might look the same, they might so, but biologically and natural history, it's very, very different. Each patient is different. So heterogeneity within that rare group is another problem. So you can't put every wild type just in one basket. That's one thing we learned. And we picked up 2 mutated GIST patients because they were referred to as wild type GIST. And we analyzed the tumor again with biopsy, but we didn't fit because one of the patients actually responded very well to imatinib, which we've never seen in our. What we see is what we call a stable disease, and we're fooling ourselves when we give imatinib to the wild type GIST patients. What you see in the natural history of the disease, not a response to imatinib. We have not seen objective response to imatinib. So if I have a patient now, I would not start with imatinib. In fact, we've been discussing the last night and the night before the SDH deficient GIST. Shouldn't we call them GIST at all? Just call them SDH deficient cancers. Because the moment you put the GIST labeling, with all the regulatory environment we live in and the commissioning and the reimbursing and everything, it's very difficult to get drugs apart from those 3 drugs you have, the imatinib, sunitinib, and regorafenib. And we know that imatinib doesn't work. Sunitinib and regorafenib, we have seen some responses, but not strictly amounting to partial responses as per RACIST or even as per Choi criteria. We've seen some slowing down of the progression, where instead of the curve being like that, the curve is like this. So we have seen some slowing down of progression. What we're very anxious about in the wild type GIST patients is knowing that the natural history of these patients is longer than your mutated GIST patients. We're very worried about the long-term effects of the multi-target kinase inhibitors in the young women. Very, very important awareness because some of the patients have been on regorafenib for 1.5 years, 2 years, 2.5 years. And we have not seen that in our adult populations in the mutated GIST because the median time to progression in mutated GIST and regorafenib is 4.8 months. So we have to be very, very careful when we put these young patients into the 2nd and 3rd line therapies. So we need to be aware of that as well. So these are actually very, very different to your adult mutated GIST. The one thing I've learned in the last 4 years is we said collaboration, but collaboration. That doesn't need to be repeated 100 times because without that we can't progress. it's very, very critical, either regional, national, or international collaboration. Innovation is another thing, because we need to think differently. We need to think outside the box for these patients. We can't just put them in the GIST box and say, this is just treat this mechanism. We need to think about how we manage the patients. We talk about tailoring the treatment to the patient, and that's what the surgical side of things, no surgery. And we said GIST treatment backends were established. And trying to engage with the pharma, difficulty is rare cancers, rare tumors, and very difficult to engage with the pharma to try and say we need trials. As I said before, and we had these 2 trials, got a cytopin trial, and John Blood, who is the CI, we've got 3 patients so far in the last 10 months, and we're desperate to open this in UK, because we already got 6 patients who are lined up. And I spoke to Professor Brigitte Wiedemann a month ago, 6 weeks ago, and we're trying to get this eliminated for the NF1 GIST patients. So this again should be an international trial, not just based on, and they haven't got any patients as yet. So I'm going to stop there. And thanks again for inviting me. It's been a great pleasure to be here, and have to take any questions how to do it.